if I told Carol to talk to Rob. Thank you. That was a good idea. Okay, she's gonna go do it.
Hello, everybody. Hopefully you can all hear me. I think we're going to wait a minute or two just to make sure everyone can join.
I can hear you, Danny. This is Barb in Cedar Rapids.
Thank you, Barb. I'm glad someone spoke up.
Good morning, Danny. It's Diane in Mason City.
Hey, Dan.
Good morning. This is Michelle and Linda from Loring Hospital in Sac City.
And we've got our new state trauma coordinator taking minutes for the meeting. Do you want to say hi, Margot?
Hello, everyone. We're also going to be recording the meeting as well.
All right, that's probably enough time. So we've got our minutes for the meeting. Hopefully you can all, or sorry, not minutes, the agenda. Hopefully you can all see that. So we're going to give a quick update about changes to the data dictionary and some NTDB validation updates. So I'll go ahead and get started with that. So I'm going to go into a demo incident here and just show something that a lot of you have asked me about, and I've probably noticed that the drug and alcohol fields are different from what they were in 2016. But ImageTrend kind of had to do something a little weird to make it all work. So since there are people still entering incidents from 2016, they kept this old field, drug use indicator. And let's see, I'll show so the NTDB releases a change log for what they're doing every summer. So the drug screen field was added, it's a new field, and the drug use indicator field was retired. And we have a similar thing for the alcohol fields. And the way that works now is the drug use field used to just have these different options. Now you need to actually select the drugs, or you can say none or not tested. And then the alcohol field is similar. So if you say yes for this, then the blood alcohol content field is actually different than it used to be. And I updated the description on here to say that it actually needs it in this format where it is a number dot number. So if you're at the legal limit, 0.08. And that's the correct way to submit it, so you won't get an NTDB flag. So those were a couple updates I wanted to mention on that. And then also Diane Williams here. Did you want to talk about the added fields that we did on the short form?
Sure, why don't you go show what we added? So on the short form was what, 3 or 4 fields shy of having all of the required elements for NTDB submission. So for those of you that do National Trauma Data Bank submission, you know that transfers, admissions, and deaths get submitted to NTDB based on certain criteria. So we did have some hospitals that were doing NTDB submissions that were using the short form because, you know, that short form is usually for the transfers, those patients you don't keep. But they were finding that they got some validation issue errors with their NTDB submissions because they were missing a couple fields on this. Originally, the guidance had been for all NTDB hospitals to use the long form. In an effort to support everyone's use of the system, we just added, or had Danny add, the primary method of payment and work-related, correct? Those are the two?
Yeah.
And so once we added those 2 fields, the short form has all of the NTDB fields that you need to complete if you have a patient that's transferred that would meet inclusion criteria for NTDB. I'm happy to entertain any questions about that because I know that's a little confusing. If you do submit NTDB and you're not quite sure what this means for you, again, you can contact Danny, Margot, or myself and we can kind of walk you through it. But I would entertain any general questions anybody has. I'm not hearing anything other than my neighbor talking to somebody else on technical assistance call. So if you can overhear Terry, sorry about that. No, you're okay, Terry. No questions? All right, Danny, back to you.
So yeah, we added these 2 fields, as you can see. And then I also wanted to mention, I've been recommending this to a lot of places recently. If there's something that you want to track on these trauma forms and you want to pull reports about, you know, in the report writer, then you can create your own facility questions here, and you can just email me about that if you want to do that. I can help you set that up, but you do that in this setup thing here. And so if you're interested in that, I just thought I'd mention that since I saw it. Okay. So yeah, NTDB validation, we mostly covered that. Another thing I wanted to mention, oh wait, wrong tab, is we've got a field, and I forget exactly which field it is, but when people select not known / not recorded, it's actually on the pre-hospital tab, and it's transported to your facility by. So if you select not known, not recorded for this, we can save that, and hopefully this will actually pop up. But for whatever reason, internally, ImageTrend is thinking this is not applicable, which is not a valid value for this field. But not known, not recorded is a valid value for this field. So I've created a ticket with ImageTrend about that. Let's see if it pops up here. Oh, no, yeah, I would have to off on this form. But anyway, if you have not known, not recorded for this and you're getting that NTDB validation issue, then you can just ignore that, and that should be corrected shortly.
How would you not know how your patient did not get to your facility?
Let's see. So I think it's a pretty rare thing. I don't. If someone else wants to chime in, then that's fine. But I was talking to someone, and I guess I forget what part of their organization doesn't always record it, because I think they might have to get it from. You know what? I I kind of forget the full explanation for that, but I think sometimes it just ends up not getting recorded somehow. All right. Let's see. And Margot is going to talk about AAAM AIS. We had our course about this. So Margot, you wanna talk about it?
Yeah, so on March 30th and 31st, Danny and I got the opportunity to participate in the AAAM AIS course held here in West Des Moines. We both learned a lot about what that was, how we were getting those scores, how useful they were in getting your ISS score, and how important they were to be accurate. So if anybody has any questions about that, they can contact Danny or I, and we can help them out. Something we did want to mention, though, Danny tells me a lot of times these AIS scores are automatically populated once you put in a diagnosis code. And something important to remember here is just to make sure that you're double checking and validating that the correct score is AIS score is coming up when you put in your diagnosis. It usually just pulls a previous AIS code that somebody has already put in at your facility. So just make sure that you're double checking, looking at that, making sure that it is the correct AIS code for that ICD-10 diagnosis.
Margot, is there a reference that you can make sure that that's correct?
Opening cut. Okay.
We got code books at the class. I'm not sure if there is something online that can be accessed.
Hey, Margot, go to the lookup that's right next to that.
That's Danny that's doing that there.
Or yes, Danny, go to that. And then look up the code, and that way, as you look up the code that popped up, you can see if that actually matches the injuries that you're anticipating. Danny, can you just search the code that it auto-populated?
Yeah.
It's just a dumb thing.
Yeah, so when you hover over it, it showed you.
Oh, isn't that funny? Crap with that.
Okay, so there you go. So you can kind of get a feel for which AIS code is popping up in association with the ICD-10 code that you've put into the system. And again, these should match the injuries that your patient had. This is very, very important because the AIS code is used to calculate the ISS code, and the injury severity code is one of the primary pieces of data that's looked at when we are using the trauma registry data for any sort of research or improvement. So it's very, very important that the AIS codes are as accurate as possible. And what we'll tell you is that I think we trained, 30 people at that course in March. And Danny and Margot are more than happy to be a resource. So if you do have one and it's just not matching, or it doesn't look like your ICD-10 code, but you're not sure how to calculate that score or find that score, contact Margot or Danny for some assistance, and they'll help you get the right AIS code for your patient.
Make sure your computer program works correctly.
Hey folks, I do know that we have a lot of lines open. We didn't mute everybody, so there are some folks that we can hear. So if you want to just double check and see if you're muted on your end, and unmute yourself if you have a question, we're happy to help.
Okay. Yeah. All right. And yeah, so Margot and I did take the class. Little caveat, I missed 3 questions on the final exam. I still passed, but Margot actually didn't miss any questions. So you can ask her if you definitely want a correct answer. All right, so Diane, I think the administrative rules.
Okay, so as folks know that we noticed So we've started the process of adopting the trauma registry rules, which is chapter 136. So the first step was to go to the State Board of Health. We did that in January and noticed the rules. They didn't have any questions or concerns, so those rules moved to the Administrative Rules Review Committee, and that is a group of legislators that reviews all administrative rules before they're formally adopted. Okay, so when we met with the legislative group, it's a group of 10 House and Senate members, and there were some questions about the data registry. During this last session, there was a lot of discussion and movement on reducing the amount of information that we have in our data systems. Most specifically, they were concerned with the Social Security numbers. The legislators are not comfortable with state agencies having Social Security numbers for people. And while those Social Security numbers are used to deduplicate data, they're used for cross-referencing patients between registries, for research purposes, we did work with those legislators and negotiated removal of the Social Security number from the data dictionary and from the data system. Well, this process has slowed us down a little bit, but we will be going through the next phase of implementing the rules. So these rules, with those slight modifications, will now go back to the State Board of Health for adoption. And then in July, those rules will go back in front of the Administrative Rules Review Committee for approval. And once the ARC, the Administrative Rules Review Committee, approves those rules, then they would go into effect. So assuming there are no more hiccups in our process, then the data dictionary will formally be adopted in July of this year. That's kind of where that's at. Does anyone have any questions or concerns with the process to this point? Okay, well, we're going to keep moving ahead, and we did meet with the data management subcommittee when we were working our way through that process just to get their input and understanding, and so that's kind of where it's at. We'll continue to move the rules ahead, and again, if anybody has any questions at any point, feel free to just let us know, and we'll be happy to address them. Danny?
All right, so I'm going to talk about CEQUIS, which I actually forget what that stands for. Diane, do you remember?
System Evaluation Quality Improvement Subcommittee.
Okay, yeah, that's a subcommittee on TSAC, and I've been working on getting some indicators calculated out of our trauma registry. So these are the indicators that we look at on CEQUIS, and basically what I'm doing is just using the data in the trauma registry, and I'm finding the results of these for each facility, and then for each level, each trauma facility level. So like, for instance, at a level 4 facility, actually I think this is the indicator 1B for level 4 facilities. How often is a trauma surgeon present within 30 minutes of the patient arriving at the facility? And so I just calculate the percentage of times that they're there. And so I do that for each level, each hospital, and then also the statewide numbers. And essentially, what we will be doing here pretty shortly is sending out the results to each hospital. So each hospital can know, according to the way that we calculate it, what their results are on this and how they compare to the average for that same trauma level that hospital is. So if you're a level 4 hospital, you would be able to see your own result for this, and then you'd be able to see the result for level 4 hospitals overall. And then you'd also be able to see the statewide result for that. So this is something that it's still in the works a little bit. I've basically got all of them calculated, but we're just working on a good, efficient method to get them sent out to folks. So this is something that I think you guys should be seeing within the next couple months. And what I plan to do is send a test email out, and then I'll just confirm that you are the correct contact at that facility. And we're just using our trauma coordinator list or contact list for that. So we can add people to that, and we can change who the contact should be for that and everything. But we're going to send out an initial email, have you confirm that you're the appropriate person to contact at that facility for these sequence indicator results. And then we're going to start sending out those results and perhaps a couple other things that hopefully will help you be able to get a better look at how you're doing within your trauma program. You can use it however you want. And maybe a few things about like if there are, like sometimes people will select an injury date that is after the admission date, for instance, and incidents like that, we might just be able to send you a spreadsheet that just says this incident has this weird data anomaly going on, and then that would help you just improve your data quality without going to a lot of work to find out what's going wrong. So yeah, that's all I wanted to say about the sequence indicators, really.
I was going to say, and Danny, this data will also, just so everybody is aware, this data will also be compiled based on service area. So those of you that are not sure what I'm talking about when I talk about service area, the Emergency Preparedness Program, trauma, and EMS are all working together to develop service areas. As part of the American College of Surgeons consultation visit we had a couple of years ago, it was recommended that we develop trauma regions. Well, we're not going to call them regions, we're going to call them service areas to be consistent with what our partners are doing. But basically, they're groups of geographical counties that are going to be working together and looking at how to problem solve within a service area. So emergency response, patient movement, trauma, EMS, those types of things all working together within that service area. So this data will be compiled based on those geographical areas to be able to help those groups have evidence to understand what changes need to be made and a mechanism to measure changes that are made within those service areas. So if you don't know who your hospital emergency preparedness person is, you should find them and link arms and get to know what they do and have them understand what you do, because there'll be a lot more collaboration going forward within the hospital's emergency preparedness programs, trauma programs, but also with public health, EMS, and other partners. So I just want to make sure you guys are in the know and that that you understand that this data will be part of that package as well. If anybody has any questions on service areas or any of that, just let us know. And Danny, were you going to show us what one of your reports look like?
Like what? Oh.
Diane, this is Cheryl up in Emmitsburg. Are you talking the service areas? Are they going to be the same service areas we're currently working with?
So the ones that are going to be implemented in July 1, on July 1?
Yep, they're the ones we've been prepping for the last 6 months. Okay, I just want to make sure we're in the same service areas. Okay.
Yes, we are. That's the whole point. So we're going to use those as the trauma regions as well.
Cool. Thank you.
No problem.
Okay. Yeah, Diane was saying, I could show an example of this. I would do that, but I don't have one prepared right now, and the only ones that I have produced have like hospital-specific information on them. So I won't show it, but basically it's just a spreadsheet that's going to say indicator 1, and then the cell next to it will just say what your result is, and then the cell next to that will say what the level, like similar level hospitals have, and then the state and the region that you're in.
Danny, do you have your presentation from Sequis?
Yeah.
Or from TSAC?
Yeah, I do. I can open that real quick.
So are you looking at those monthly, quarterly? how often is the data going to be put out?
Well, it could be. I don't know. I guess it depends on how useful it would be. But we were thinking at least quarterly we could do this stuff, and also different hospitals. Like some hospitals enter the trauma incidents like right as they're happening. Some of them are more delayed than that, so it's not always going to be like not every hospital needs to have it like for the most recent quarter right away because they don't have the data entered. So I guess we'll have to figure out a schedule for that. But is there any time interval that you'd be interested in?
I would say quarterly, if not, or quarterly would probably be good.
Okay.
Because then you can really look at it and do something about it sooner than later.
Yeah. Yeah.
Well, and the other thing is that if, as you get into a cycle and depending on your own meeting cycles, if you want it more often than that, all you need to do is make the request and Danielle can pull it and process it for you and send it to you.
Okay.
And as I understand, Danny, that's only like once all the algorithms are set up. So what takes 15 minutes maybe for you to do that for a hospital?
Yeah, and really even less than that. So once I do have it set up, like Diane said, everything will already be set up. So all I need to do is pull the data from Image Trend, run run basically a program, and then it will spit out the data. And so yeah, if you have a specific time frame that you'd want it, then you can just contact me directly about it.
Okay.
The other thing I think is going to be important is that this will be sent secure mail. So we have gone Google and like the data will have your hospital specific data, and while that data is all aggregated, it is still considered from our perspective confidential because we don't provide to the public your specific hospital information. If you want to do so, that's your privilege. So we'll probably have to work it out in the world of email if there are firewall issues with the hospitals, things like this. And that's why Danny had talked about doing that test. But we'll make sure that we're sending a message out non-encrypted so people recognize to look for it so we can identify if there are firewall issues with the delivery.
So the example Diane was talking about is this is just the template for it. We'll have all the indicators, not just these first two, and then like this is just an example of an indicator that it's not a sequence indicator, but it's something that I think might be useful to hospitals because this is something that we look at for the re-verification of facilities is how many incidents are submitted within 60 days of the discharge of the patient. So this can be a way to keep track of something that we actually look at when we re-verify facilities. So this basically would be an Excel spreadsheet that would be sent out to all you folks, and hopefully it would be useful to you guys.
As we're talking to 46 different trauma coordinators, is there anything that you want to see? Anything you want to know that isn't here?
Diane, can you
Up that list.
a copy of that indicator slide that you had up before? Yeah, that one, of the email.
Yes, absolutely. And so right now we're working on the hospital system, not we, Danny. Danny is the man. He is working on the hospital system indicators. We'll progress to get the out of hospital system indicators as well. The EMS registry system isn't as far along as our registry system. They had to go through, so they went to a new system and then had to do an update to that system as well. So they're still getting all of their people to the newest platform and getting it rolling. So that will be coming, but it's not ready yet.
I would like to see maybe admission to hospital other than a trauma surgeon or trauma services.
Non-surgical admin.
Mm-hmm.
Okay, that's actually a good suggestion. As far as non-surgical admits, and are there any qualifiers or anything else that Danny needs to look at? Are you looking at like a high ISS or just any, or are there any qualifiers?
Basically, a trauma-specific patient admitted to non-trauma services.
Okay, so broad. Okay.
But
Could
you
we
take
do that with an ISS over 10?
with the other surgical consults, that same level fall, ISS less than 9, all those that the ACS says that you can kind of pull those out. I don't know if we want to get more specific or leave that to hospitals to try to determine that.
Okay, so that's I guess the question that I would put, and we can take that to Sequis and have them give us guidance too. Danny, didn't they have you looking at something like that? Do you remember?
Which one are we talking about now? Is
I
it
think
the ISS one or the non-surgical or non-trauma admit?
the non-trauma admit. Did Sequis have any qualifiers on that or not?
I don't believe so. The only thing I know is that I think the ACS does look at, like, you know, I think it's 10%. You're supposed to have less than 10% non-surgical admissions.
But they exclude patients with a certain ISS, isn't that correct?
Yeah, less than 9, same level fall or other surgical consults are in there as well.
Okay.
So that would be appropriate.
Okay. Margot, did you capture those?
So I've got non-trauma admits, a percentage. Was there a second one?
What the ISS level, so excluding ISS level less than 10, excluding same level falls, and excluding patients that were seen by a surgical service. Is that correct?
I think so, and then there's drowning and hanging, I think, in there.
Okay, so excluding drowning and excluding hangings.
I'm trying to figure out the page on the ACS Orange Book that has those qualifiers on there, specifically in the PI section.
Okay. Yeah, we'll see. Barb, if you can find that and email, that would be fantastic.
Will do.
And is the rest of the group in concurrence that would be useful to you? And or are there other things that would be useful as well?
Can we think about it and get those suggestions to you? Or to
Absolutely.
Danny?
Yes, absolutely. No, this is the final answer. We won't give you any more.
So you're done, you're toast, right?
You're all good. You're all good. And I think that this is going to evolve. So as we provide this data to you and you take a look at the indicators as they exist, and that is going to prompt you, like PR within your own hospital, that's going to prompt you to ask more questions or dig deeper in different areas. So I think that this will evolve over time. So don't hesitate to ask for those types of things as you need them.
Diane, I do have I'm sorry.
Very useful and for our quality committees and projects also.
Absolutely. And this ties back to our really big push over the last couple of years to make sure that people are getting their data into the registry, that data is quality and timely. And you're going to see that as we push data back out to people. You know, if it's not quality or timely, that will be evident, I think, in the data that comes back out. So whatever you need from us to help support your data input and getting it in the system, we want to know that too. Margot, I think you had a question.
Yeah, I just got a quick question through the chat here. Wanting to know if they are supposed to submit same level fall hip fracture.
So it's an all or nothing is where we're going forward. If you were going to put your same level fall hip fractures in, we want you to put all of them in. If you're not going to be able to do all of them, then none of them. And if you we'll be able to see based on your data if you're putting them in or not, but it would be nice for you to just shoot us an email and says, hey, we're intending to track all our same level fall hip fractures. We're hoping a few hospitals will do that, at least enough to create us statistically significant number, so we can extrapolate and get a feel for how that's moving across the entire system. We do understand, and after lots of conversations with trauma coordinators and other trauma system experts, it's data that we need, but it is also an extremely large burden. So we are trying to find some balance. So all or nothing.
Diane, did you have a start date on that? I was thinking we didn't have that yet.
Well, technically that would be when the data dictionary is adopted. But if you want to create a line in the sand and say, this is when we're going to start doing that, we would not stop you from doing so.
Okay.
Originally, when we started with Image Trend, you sent out a paper audit that we could use for like the short form. Is there anything available, again, now that we've kind of done some updates with that short form? Is there a paper audit tool?
I don't have one. I do remember what you talked about, and some of the trauma coordinators had done that.
Yeah.
Has anybody on the call kept that up or updated it?
Can you repeat that one time?
There's a short form paper audit sheet that would originally came out to kind of help those of us that, you know, don't have those double screens. And I just wondered with an update that's been done with the short form, if anybody else had updated that audit sheet.
Do you have is it in Word? Is your audit sheet in Word?
Oh my goodness. Yes, I mean, I think it is. I'd have to even go back and even figure out where, you know, originally was the email. It probably long gone, and I've just made paper copies. So
Oh, okay. I was gonna say,
have it.
if you can find the electronic version of that and send it back to us, we can kind of take a look at it and
Okay.
see if we can scope through and see what's changed.
Okay.
Okay, any other thoughts or questions? All right, Danny, let's take us back to the agenda. I think that was all that was on the agenda, wasn't it? Did you have anything else?
Yeah, I think that was the last of it. Something I wanted to mention real quick is if any hospitals are going through the re-verification process when you're filling out your SACA, if you want help pulling data out of Image Trend to fill out some of that form, I've been doing that with a lot of facilities, but yeah, if you're interested in that, then please just contact me about that, and I can get those numbers pretty quickly for you.
Okay, thank you. And I also have a couple sort of not on the agenda updates for the greater good if folks are open to that. So we are working on doing a statewide rollout of Stop the Bleed. I don't know if everybody is familiar with that campaign, but it's a hemorrhage control campaign targeted at teaching the general population how to take make life-saving interventions, including wound packing, compression of the wound, and then also application of tourniquets. So this is a national campaign, and there are pockets of implementation going on all across Iowa right now, and we're trying to create a big statewide movement. So we are going to be offering Train the Trainer courses on June 7th in Central Iowa, June 20th in Western Iowa, and June 27th in Eastern Iowa. I'm working with our vendor right now to get registration set up, and as soon as I have the registration, I will be sending out a blast notification to everyone. And we're not looking just to trauma, we're looking to trauma, emergency preparedness, public health, law enforcement. This is going to be a huge campaign across the board. So I just wanted to give you a heads up that this is information that will be coming out very quickly. And then in addition to that, we are looking at doing once we have trainers established across the state. So we're going to do our Train the Trainer sessions. Those trainers can go out and do Train the Trainers within their own local jurisdictions to create a large cache of training capability, sort of like the same thing with CPR. We have CPR trainers all over. We want to create the same thing. And then so come late summer, early fall, we will be doing a widespread statewide media campaign. I've even heard that we may be approved for billboards, things like that, to create the information and the awareness amongst the general population for the Stop the Bleed campaign. So this is a prevention and outreach gold mine for those of you looking for a nice, easy prevention and outreach project for your hospitals. This is a good one. All of the materials and information will come packaged. I believe the Iowa trauma coordinators are going to do a training session at their conference in June. And like I said, there'll be other opportunities coming out over the next several months. So that's big news coming your way very soon. Anybody have any questions on that?
Yeah, Diane, so the Iowa Trauma Coordinators Conference will be actually certifying us to teach these classes or just giving us an overview?
I honestly don't know for sure. I talked to Jennifer Nutt a few weeks ago, and she was going to be checking into kind of which way that fell, and I haven't heard back for sure.
Okay.
Sorry.
Will you give us the date? Will you give us the dates again?
Sure. In Central Iowa, it will be June 7th. In Western Iowa, it looks like we're going to go be in Council Bluffs on June 20th, and then probably at the UIHC or Iowa City on June 27th. And again, we'll get trainers in, and those trainers will be able to come back and train the trainers in local areas too. So if you're not able to make this, find a friend that is, and they can provide information, provide that training in local jurisdictions as well. And there are already some trainers. I know we have trainers in Spencer, there's trainers in most of the major metropolitan areas. So it's going to get out there fairly quickly.
Hey, Diane, this is Barb in Cedar Rapids. I'll just put a blip out there. We have a Train the Trainer coming up on next Wednesday, the 10th, and I still have some openings in ours because we're putting it out as a 6A district kind of training, but I probably still have 8 spots if anybody is on the call and they would want to attend that. We have it next Wednesday at 10 o'clock here at Cedar Rapids, St. Luke.
That's fantastic. Cool. We're also working with the training centers, the EMS training centers, to get the information out as well. So, like I said, make sure this is on your radar. Find a training session that you can go to, hopefully one that's close to home. And let's make this happen. Barb, do you know if they're using the ACS curriculum? Are they doing all their stuff through ACS?
Yeah, Dr. Sidwell is actually coming to do it for us.
Perfect. We are putting together a website as well. So on the IDPH website, you'll be able to find Good Samaritan fact sheet. I'm actually writing that fact sheet right now. The Good Samaritan law will cover any private citizens who volunteer to take action for this hemorrhage control project. And then there will be a bloodborne pathogens fact sheet as well. There'll be links to all the promotional and educational materials and links to the American College of Surgeons, including links to the class registration. So the American College of Surgeons is hosting a place for people, if you're hosting a class, you can put that class out there and then people can find your class through that mechanism. So like I said, all of those things are under development and should be ready to roll by June 7th.
Will you be sending out this information for people to get registered for this?
Yes, I will. I'm telling you because we have you on the call right now, but I hope to have the registration information by Monday or Tuesday of next week. And at that point, and if I don't, then I'll send a save the date out, and then we'll follow that up with registration as soon as possible.
Okay, thanks.
Yeah, no problem. I'm looking at my list, trying to think of if there's other big stuff going on. There's a lot of stuff going on, but I think that's the biggest one on the radar right now. Does anyone else on the call have anything for the greater good? There's one other thing I do want to mention. We are working on getting a, I don't know if it's actually going to be called topic, but it's the performance improvement class, very specific to rural facilities. So our 3s and our 4s. We're Jerry Babb and the Society of Trauma Nurses is working to find us an instructor to do a class specific to 3s and 4s, and I think they gave us a contact at Parkland in Texas. And so we'll be reaching out, and hopefully before September 30th, but probably the August-September range, we'll be doing some performance improvement training for our rural facilities. And I think that timing will work out really well because you'll have data from the registry as well that you can use for performance improvement. So just keeping that on the radar. I think that's all I have. Danny, is there anything else that you have, or Margot?
I don't have anything else to say.
I don't think so either.
Okay, so folks, anybody on the call, anything else to add? All right, well, thank you so much, all of you, for your time and effort and all the work that you do. We genuinely appreciate it, and we will talk to you soon, and we'll be sending emails shortly. Thanks.
Thank you.
Thanks, everyone.
Thank you. Bye.